Hello, everyone. Good morning. Today's edition of Patcast. We are sorry for the delay and extremely sorry for the inconvenience. And once again, we are back with Dr. Fausto Rodriguez today from Johns Hopkins Hospital, and he is going to continue his Neuropath lecture series. And today is his 8th lecture in this 11 lecture series. And today's talk is going to be on choroid plexus tumors. I hope you guys had a chance to have a look at the virtual slides that was shared. So over to Dr. Rodriguez, please, and please feel free to share your questions and comments on WhatsApp, Facebook, as well as YouTube. Thank you so much. So Dr. Rodriguez, please.
Okay, as always, a pleasure to be with you again. Today we're going to cover a very specific topic for surgical neuropathology. These are the choroid plexus tumors. In the WHO classification, there are currently 3 tumors that are actually considered under this rubric. So there are not that many tumor types, but these are a specific problem with very challenging differential diagnosis and highly relevant for a pediatric surgical neuropathology in particular. So let's start with case number 1, which is a 40-year-old woman that had a history of a pancreatic neoplasm, which she was being followed for, and then developed a brain mass through routine follow-up. Actually, it was very large when they discovered it. So this is the mass, and it seems to be in the right hemisphere and appears to be related to the lateral ventricle. This is case number 1. And you see a lesion at low power that's very calcified. We're going to be moving around. There is some cautery or crush artifact, which is not uncommon with these tumors. They tend to be vascular. Occasionally, you may even have embolic material. Not in this case, of course. Papillary and epithelial architecture. And you start seeing that there's an interface with adjacent brain. And this is something that when you have it in these tumors, it's not uncommon. You have pyelogliosis. You have a very reactive glial proliferation in the brain. Sometimes you even get the impression that there is some brain invasion. But that is not a prognostic factor, really. I mean, it's something that is not uncommonly seen when you have this nice interface. Here you see more of this papilla. So, of course, here you have a differential diagnosis. And one thing that we see is that the cells are bland, and there really is not much for proliferation, mitotic activity. Very bland epithelium. So the patient has a history, of course, of adenocarcinoma. That will be here the main differential diagnosis. We have some stains as well. I'm going to cover. Starting with cytokeratins, CAM 5.2. So this will be the marker that's going to be most frequently positive in these choroid plexus tumors. So cytokeratin is essentially present in all. That was CAM 5.2. This is A1A3. That is a more focal, but still present. CK7, some CK7 positivity. CK20 negative. On occasion, you can have some focal staining as well for that. And this is Ki67. That goes well with a relative absence of mitotic activity. So the diagnosis here was choroid plexus papilloma, WHO grade 1. The main differential diagnosis, again, was here with a metastasis, but we saw that the features were bland, and certainly you can have more than one tumor developing. Moving to the next case, we have a 65-year-old woman with a fourth ventricular mass. This is the virtual slide. And again, you have a tumor that appears to be epithelial. You do have some vessels, relatively vascular. Some hyalinized vessels, which go well with chronicity. More hyalinization here. So a lot of chronic changes. And more chronic changes here. And this is a feature that I want to highlight the most here in this particular case, is that you do have a very compact area of gliosis. And here it extends here, a lot of hyalinized vessels. In this case, it's very easy to go in the direction of a glioma or a pilocytic astrocytoma. You have more of this here, vascular hyalinization, increased cellularity of the glial component, and even some atypia, you may argue. There are a few epithelial strands here. So you may have a bit of involvement, but really the lesion is here. And since it's in a ventricle, the main thing that you have to consider whether this is really just choroid plexus next to another tumor. But the atypia in these papillary areas is a bit more accentuated than you will expect for a normal choroid plexus. So The diagnosis here was essentially the same as the previous one, choroid plexus papilloma, but we had a bit more striking gliosis in this case, which raised a different set of differential diagnoses. You can have a lot of these. You can have, even as I mentioned, the suggestion of brain invasion, but it's not really a big prognostic factor. It's something that can happen. The main thing that you want to look for in these for grading is proliferation. And in this case, as the first one, the proliferation was low. Moving into case number 3, we have a 31-year-old man with a left lateral ventricular mass. And again, we have something here. You argue that there's some gliosis, and you have a tumor that is papillary as well. What is striking here is that you have a more pronounced variation in nuclear size in hyperchromasia. Hyperchromatic nuclei, and even more accentuated here. However, as you move around, the proliferation is very low. And we had a very low Ki67 as well, labeling index. Variation in nuclear size. So actually, this was also another choroid plexus papilloma, showing you several examples of some of the variation that you can see with more degenerative type of atypia. You can see this in a variety of tumor types. Essentially, every major category of neoplasm in the CNS can have some sort of degenerative atypia. In the absence of more pronounced proliferation, usually these are still compatible with lower grade neoplasms. So this was a choroid plexus papilloma in which you had more variation, more type of degenerative atypia, which was still compatible with a WHO grade 1. Moving to the next case, number 4, moving more into pediatrics. This is a 7-month-old child who had increasing head circumference in a right lateral ventricular mass. And this one is a little bit different. Again, just seeing maybe here the main thing, of course, that catches your eye at low power is this abundance of hyaline cartilage. That is not very atypical. You have some cell clustering, but looks like bland, benign cartilage in association with epithelium that seems to be flat to cuboidal in areas and simple. But with tufts in other areas. And this is much more than you will see just with normal choroid plexus. So this is actually neoplastic. And even though this is dominated by the cartilage, you still have histopathology here that is compatible with a choroid plexus neoplasm. Not very proliferative, kind of bland, and a lot of these cartilage islands. This is really a striking presentation for this. No other epithelial components. You have to start thinking whether this could be a germ cell tumor. We don't see anything else that will support that hypothesis. There's some blood. Let me see what I have for stains. Actually, the main stain that we had here was a PAS, which actually stains very beautifully the hyaline cartilage. All these nodules. So unusual morphology, but again, we're not seeing much for proliferation or anything that will significantly impact prognosis. So the diagnosis here actually was choroid plexus papilloma with chondromatosis, or what should be considered hyaline cartilage metaplasia. And this is a rare phenomenon, but it has been described. And as other tumor types in the CNS, choroid plexus neoplasms can be very, very versatile. They can have metaplastic changes and other things. It's always, again, try to focus on the epithelial component in these cases and see in the proliferation will be your main clue whether this is something that is likely to behave more aggressive or not. A grade 1 tumor can disseminate or can cause problems, but in this case, really histologically, it's still compatible with a WHO grade 1. It's in the same spectrum of these, of the changes that you can see with choroid plexus neoplasms. Moving to case number 5, we have a 63-year-old woman that presented with a generalized seizure. And this is the MRI. And we are looking at a lesion that is involving the right cerebellopontine angle. Here is, and it's enhancing. This is a T1 plus contrast, and we're seeing several levels here. I wanted to show you, showing that it's associated with a CP angle, but it actually has a connection to the fourth ventricle. So it's in this foramen of Luschka, which are the lateral foramina that interact with the fourth ventricle. So in part is associated with the ventricle. And as you can tell, we have a theme. We are having another tumor that has a lot of papilla. Very similar to the other cases I've been showing you. Nicely developed papillary architecture. We have some hyaline deposition here. And we have even some dots. And probably we're starting to see some mitotic activity. Another one here. So in this case, compared with the other ones, we do see some increased proliferation. Not much atypia. So it's sufficient atypia to be able to recognize it as neoplastic choroid plexus, or choroid plexus neoplasm, but not the most striking. And the proliferation is there, but it's not overwhelming. Or this tumor, some fibrin, some hyalinization, and we have some stains here as well. Here is CK7, which, as I mentioned, is frequently positive in these tumors. It's not specific, but is frequently expressed to variable extents. This is synaptophysin. And we didn't talk about this, but synaptophysin is also variably expressed in these tumors. Doesn't mean that the tumor is a neuroendocrine neoplasm, but as many other primary neoplasms in the CNS, you can have synaptophysin staining. It's usually patchy, variable. This one had a little bit more synaptophysin. And this is S100, which is frequently positive as well in choroid plexus neoplasm. So keratins are the main markers that you're going to see to be positive, but you do have S100 also to be, you find it frequently expressed in synaptophysin as well. Now the main, we did a lot of also transcription factors to exclude a MET here, including CDX2, TTF1, all those were negative, as you would in any, evaluate any papillary neoplasm. And this is the Ki67. And you start seeing that compared to the other tumors that I was showing you, you do have patchy increased activity that goes well with the mitotic activity. So you have a choroid plexus neoplasm that actually has an increased proliferative activity compared to the other tumors that I was showing you. So the diagnosis here is atypical choroid plexus papilloma, which is assigned at WHO grade 2. So the main criteria for this is proliferation. There's been some data to support that mitotic activity in the excess of 2 mitosis per 10 high power fields is compatible with an atypical choroid plexus papilloma diagnosis. It tells you that you cannot allow too much mitotic activity in choroid plexus papillomas. Most of them have none. You can have a rare one, but once you start getting above 2 mitosis per 10, you have to be worried. There's no other significant atypia or areas of necrosis that will make you consider a carcinoma, but here we have an atypical choroid plexus papilloma. And this diagnosis is not trivial. Actually, this patient died subsequently, had some progression in hemorrhages as well, so ended up dying sometime after the diagnosis. So these can really cause serious problems. Moving next to case 6, 1-year-old girl with a left lateral ventricular mass. Okay, seeing number 6 here. 8, but not 6. Okay. So for whatever reason, I'm not showing number 1, 2, 3. Okay, so but we have some slides here for this one. Okay. There's this case. And this looks different from the other lesions that I've been showing you. You have some papillary architecture, but areas that appear a bit more solid. You're starting to see necrosis, patchy of necrosis. That's worrisome in these tumors when you start seeing necrosis to this extent. And then you start seeing pink cells. This case is actually very telling and useful because you're seeing here entrapped normal choroid plexus or non-neoplastic choroid plexus for comparison. So the non-neoplastic choroid plexus has this more cuboidal pink appearance compared to papillomas that start seeing more columnar epithelium, and then you have overtly atypical papillary architecture that goes more with a carcinoma. So there's a lot of variability for a carcinoma. But in, let's see, in the pediatric population, this is a more straightforward diagnosis to make because, of course, here the main differential diagnosis is with metastatic carcinoma, and that is not usually a problem in the pediatric population. Now, something else that we're starting to see is areas in which you have some cytologic variability, but also cells with more pink eosinophilic cytoplasm. Here you start seeing more overtly detached papilla. You do have atypia. You do have mitotic activity, including atypical mitosis. And more of these pink eosinophilic cytoplasm. So the diagnosis here is choroid plexus carcinoma with oncocytic change. And oncocytic change is not a feature that is a prognostically important feature. It's just some part of the variation that you can see with these neoplasms. This one had enough proliferation, atypia, necrosis, had all the factors that allowed us to arrive at that diagnosis. And in the WHO grade, they only go to grade 3, regardless of how high in the scale they are with respect to atypical features. The main differential diagnosis in this age group is not really necessarily metastatic carcinoma, but atypical teratoid rhabdoid tumor, particularly in tumors that have a lot of solid areas, because there's a lot of variability to atypical teratoid rhabdoid tumor. Some of the early literature for choroid plexus carcinomas and ATRTs, there was some paper suggesting you can have some choroid plexus carcinomas with I9-1 loss, and that is not really considered valid anymore. So if you have something that looks really epithelial and has I9-1 loss, you probably are most likely dealing with an ATRT. rather than a choroid plexus carcinoma. Almost by definition, choroid plexus carcinoma do not have I91 loss to any significant extent. Okay, case number 7, another young patient, 10-month-old girl with a lateral ventricular mass. So it looks like here is case number 6, which was temporarily missing from the system, it looks like. So we are in case number 7. So we have another tumor that has a subtle papillary appearance. You do have atypia. You do have hyaline globules. That is another feature that is typical for this tumor. You also have clear cytoplasm. Reminds you a bit of this clear cell carcinoma. So you can see in other organ sites, gynecologic tract, etc. Hyperchromation, multinucleation. More of these abundant clear cytoplasm. Some really detached cells, and you see here, you can even argue that there are some cells that resemble rhabdoid cells. So here is imperative to exclude atypical teratoid rhabdoid tumor. This particular case, the I91 was actually preserved. But a lot of cytologic atypia. Here, the proliferation was a little bit more variable than the previous case. Here you have that. So some variation. There is some mitotic activity. I know for sure in many areas. This one had actually several blocks, and there was for sure areas of brisk mitotic activity. So this is more compatible with a malignant neoplasm. And is the diagnosis was also choroid plexus carcinoma, WHO grade 3. Wanted to show you several different pattern variations in this tumor. What are the hallmarks? Young age. Choroid plexus carcinoma is almost always limited to very young patients. So, and that is very helpful in the differential diagnosis because metastatic carcinoma is rare in young patients, and metastatic carcinoma is more frequent in older patients. So in older adults, particularly, the diagnosis of choroid plexus carcinoma is almost always mistaken. So that's something to have in mind. This patient actually was treated and very aggressively, and a few months later developed an orbital mass which was resected and actually showed histologic evidence of rhabdomyosarcoma. So it had a sarcomatous sarcoma developing on top of everything else. So the main why that is relevant is that a substantial number of these patients actually have germline mutations for p53 and are part of the leave from any genetic syndrome. So this diagnosis requires probably genetic counseling. And not only that, is that you have to make sure that when they get treated, particularly with radiation, they have a high frequency and they are predisposed for the development of sarcomas. And that was the unfortunate outcome in this patient with who subsequently died of his disease shortly after that diagnosis. The final case is a 73-year-old man that developed memory difficulties and mood swings and had a right temporal lobe cystic lesion identified. Here you have papillae. And again, you have these calcifications. These are very common in choroid plexus epithelium, so something to have in mind. These are areas of hyalinization and calcifications that you see that in choroid plexus epithelium, particularly with age. There are frequent incidental findings in CT scans. But in addition to that, you have this NES. More of this NES. More of this here. Or here. We do have some stains, I believe. Some cytokeratin CAM 5.2, which is positive, although a bit more variable than typically seen with choroid plexus neoplasms. TTF1 was focal, but still convincingly positive in a subset of cells. CK7, kind of weak. Have to bear in mind here that you have quite a bit of cautery as other tumors that we saw earlier. And this is not uncommon in these biopsies or resections from the choroid plexus, but you can argue there's a little bit of CK7. A1, A3, patchy, but positive as well. So, let's see, P63, some positivity as well, focal. So actually, this was metastatic non-small cell carcinoma. That was the diagnosis at the time. I believe lung mass and carcinoma was identified subsequently. So the main message of this case is that when you have a 70-year-old with a neoplasm in the choroid plexus that you feel that you want to make into a choroid plexus tumor, particularly carcinoma, again, you're most likely to be wrong, and it's that choroid plexus carcinomas don't occur in other patients for practical purposes. It's most of the time you have a diagnosis of carcinoma, you have to do your evaluation as a carcinoma of unknown origin, do all the stains that you will do to try to specify the primary site. It's not always possible, but in many times this may be the first presentation may be in the CNS. So that's something to have in mind, that when you have something really that looks for sure atypical, you can have papillomas in adults, and I show you some that occur actually in even somewhat older patients. But when you start having something that you're concerned that is malignant, you're most likely going to be dealing with choroid plexus. And it makes sense, since the choroid plexus is actually a very vascular organ. The other tumors that we didn't discuss, you can have a variety of tumors, either primary or secondary. You can have meningiomas. Interventricular meningiomas can be associated with choroid plexus. If you look at autopsy specimens, for example, you will see frequently arachnoidal cap cells related to the choroid plexus, which are the presumed origin of meningiomas. So you can have meningothelial neoplasms and more florid meningothelial hyperplasia in some instances associated with choroid plexus. That's another lesion that we didn't illustrate, but that can happen. So that ends our cases for today. So next we're going to move into some multiple choice questions to discuss some of the topics that hopefully I was able to highlight. So question number 1, choroid plexus papillomas most commonly express which of the following? Giving you a few minutes to take a look at those and think about it.
Yeah, I can see some answers coming, but let's give 1 minute. Cytokeratin is one answer that I can see from some. It's A. Yeah, I think more
Excellent. So
of A.
cytokeratin probably is one of the most useful, and most commonly, almost all papillomas have cytokeratin of different type. You can have, as I mentioned, you can have variable GFAP, less so, but S100 and synaptophysin are also commonly positive. But cytokeratin for sure is uniformly positive in these tumors. EMA is an epithelial marker, but actually in the low-grade tumors, choroid plexus papillomas usually don't express much for EMA. EMA tends to be more positive in carcinomas or ependymomas, which sometimes are entering the differential diagnosis, particularly when they have more papilla. But EMA is not as common. Cytokeratin for sure is very common in choroid plexus tumors, and papillomas in particular. Next question. 25-year-old man presented with headaches, and a mass in the fourth ventricle was discovered. Histologic examination demonstrated an epithelial neoplasm with a papillary architecture. 3 mitosis per 10 high power fields were identified. What is the most appropriate WHO grade for this tumor?
I can see grade 1, that is as one option that's coming. Let us see more. Yeah, I also see someone saying B, that is grade 2.
Okay.
Yeah, there is more of B. Yeah.
And actually, probably B is appropriate. One, I guess, is appropriate in the sense that I think we're feeling that this is not really a malignant tumor, that you're dealing probably with some choroid plexus papilloma of some kind. Now, the criteria for papilloma, atypical papilloma grade 2, is usually related to increased proliferation. And we use more or less the cutoff of greater than 2 mitosis per 10 high power fields. So about 3 is fine. Once you start seeing 5, 6, 7, then you have to be more concerned about a choroid plexus carcinoma. But as I mentioned, usually choroid plexus carcinoma is something that occurs in young children. So those are things that you have to have in mind. Metastasis is less common. You can, of course, get a metastasis in a 25-year-old, but it will be less frequent to have that. You tend to have more metastatic presentations in older patients. Question number 3. 1-year-old boy underwent resection of a mass in the lateral ventricle. Histologic sections demonstrated an epithelial neoplasm with abundant mitosis and necrosis. I91 expression was retained. So what will be the further germline genetic testing recommended in this patient?
I see people calling it RB1, that is D, 1 or 2. Let's wait for a couple more. TP53 is also chosen. There is more of E, that is P53.
Okay. So this one, it looks like it was a tough one. We didn't discuss it very much, but it's actually P53. So I was trying to show a correct description of a choroid plexus carcinoma. The negative INI1 was to exclude, of course, ATRT, so which is another tumor that may be associated with an inherited predisposition syndrome. But P53 is the gene altered in leave from many, and actually choroid plexus carcinomas, although they are uncommon even in this population, about up to 40-50% may have actually a germline mutations in P53 and satisfy criteria for Luframeni. So a diagnosis of choroid plexus carcinoma should trigger a genetic counseling or genetic consultation to exclude the possibility of Lee-Frameni syndrome. The other genes that I mentioned, you have a DICER1, you have a DICER1 predisposition syndrome. Those tend to be associated with ocular medullopitheliomas, pineoblastomas, pituitary-blastoma. I91 SMARB1 is associated with rhabdoid predisposition syndrome. Remember that on very rare occasions, you can have other alterations in other proteins of this complex that may be associated, like SMARC A4, I believe. But most of the time it's I91 in the brain. P10, you have Cowden syndrome, RB1. You tend to have, you can have, of course, retinoblastoma. This is part of the retinoblastoma predisposition syndrome, but you can also have epinoblastomas and occasionally embryonal tumors of the suprasellar region. Question number 4. 75-year-old man presented with a solid mass involving the right lateral ventricle. Histologic examination demonstrates an epithelial neoplasm with papillary architecture. The most likely diagnosis is
I see an answer choice as metastatic adenocarcinoma by some. Yeah, there is more metastatic adenocarcinoma as the choice. Yeah.
And that is the correct answer. I'm glad that you were able to focus on this very important issue for differential diagnosis. So 75-year-olds, for practical purposes, do not get choroid plexus carcinomas. You might find the occasional case report or something like that, but choroid plexus carcinoma, on its own, it's a rare diagnosis to make. And in particular, it's super rare to make that in another patient. You really, even if you don't have a primary, I will probably say more compatible with metastatic adenocarcinoma if I have a lesion that I'm considering calling a choroid plexus carcinoma in a 75-year-old man. So the other lesions there, of course, are in the differential diagnosis. Ependymoma is an important differential diagnosis of choroid plexus tumors, particularly the papillary variant can look very similar. So again, EMA-like positivity and less frequent keratin positivity is more of what favors more an ependymoma neoplasm. So that concludes today's session. Just want you to alert you there are 3 more lectures that are part of this series. In the future, we may consider doing others as well, but at least for the plan in the short term, we have germ cell tumors next month, so stay tuned. And of course, if you miss some of these, you can access them in the playlist that was created for Neuropath Pathcast. So thank you for your attention and hope you found this useful. Please send us your questions. Feel free to reach out to us. Thank you.
Thank you, Dr. Rodriguez. Just one quick question I found online that how to differentiate from an adenocarcinoma. And they thought that that's the important differential. And what is your thought about that?
That's right. So it depends again on the choroid plexus. One thing is age is one. You can start with age. If you have a very young child, it's going to be a choroid plexus neoplasm. Older adult, most likely it's a metastatic carcinoma. You can start there. That kind of narrows your thinking a little bit. So then you start seeing the benign ones. So choroid plexus papillomas at the benign end of the spectrum, the tumors, they tend to be EMA negative and very bland. You almost see no mitosis. You have very low castic-serum proliferative index. Of course, none of these are absolute, but when you have something that has very low proliferation inside the ventricle, that tends to favor more papilloma. If you start considering carcinoma, as I mentioned, carcinomas are almost always limited to very young patients. So in metastatic adenocarcinoma, you don't see it in young patients. And I'm talking young, 1 to 2 years of age. So again, there are outliers and there are things spread around, but a very young patient, if you have something that looks very aggressive carcinoma, more likely to be choroid plexus carcinoma or ATRT, which you have to exclude with INI1 staining. And at the under end of the spectrum, 70, 65, 70-year-old, you have something that you think maybe a choroid plexus carcinoma, most likely is a metastatic adenocarcinoma.
I think that's all that we have for questions. And there was another question about markers, but you might have already answered that in this question, I guess, unless you want to add anything more about markers.
Yeah. When you're dealing with an adult, you may want to actually do a wide panel of stains for markers, TTF1, NAPS, and everything you do for metastatic adenocarcinoma of unknown origin, CDX2, like we did that, for example, for that patient that had a history of pancreatic adenocarcinoma, and compare it. Also, if you have a history, it's very useful markers, and those markers will be negative in color. But they express, again, other markers that are more, if it expresses, you have a well-differentiated papillary lesion, expresses in addition to keratins, they are negative for EMA usually, and they may express variably synaptophysing GFAP and S100. So if you have that kind of profile, that in some way support choroid plexus papilloma.
Okay, then thank you, Dr. Rodriguez, for this choroid plexus neoplasms, and thanks to all our viewers. So we also have Neil from Philippines, and Francine from Brazil, and so many others from India and other parts of US as well. So thanks again for all your support, Dr. Rodriguez will be back again with his 9th lecture of the series. So that would be on October 29th. That is Tuesday, 8 a.m. on germ cell tumors of the central nervous system. So stay tuned and please like our Facebook page, follow the Facebook page for lectures, and also subscribe to our newsletter. And don't forget to subscribe to our YouTube channel, that is Patcast. Thank you, everyone.